what I'm going to discuss is the tools that actually stop the virus. In light of what we have heard in this past session, public health officials have a difficult job. And one of the reasons they have a difficult job is because people are spreading disinformation on things such as how does the virus spread? And that's where I'm going to step in this session. The pathogen, just like other infectious diseases, spreads from an infectious person. The pathogen has to exit the body and it goes through the mode of transmission to enter another person, and then it actually has to infect them. This is clear science, and it does not require randomized controlled trials or looking at the data from public health departments which confirm some of these tools. To have an infectious pathogen, it has to spread to others. Tools to discover this include screening for symptoms and testing, but for COVID-19, the key is you have to rapid test. Then the pathogen has to exit the body. This changes based on how the virus or the pathogen transmits. Since COVID-19 transmits through the respiratory tract, the source controls a mask. Then you have to look at the mode of transmission. It can vary from pathogen to pathogen, and that determines how you have to mitigate it. This is something that is taught in public health. For COVID-19, it's shared out, but it's not like that for every disease. And you can get rid of the virus by it being inactivated, ventilated or filtered away, getting on objects or surfaces, or inhaled. The best way to get rid of it is to actually ventilate it away. Getting it on objects or surfaces for this pathogen, due to the modes of transmission, is very good as well. And of course, you don't want to inhale it. So once you go through mode of transmission, the pathogen still has to be mitigated, or else it's just going to enter the body. And how you do that is by using appropriate PPE. For COVID-19, to stop inhalation, which is a lot of concern, you need respiratory protection. Notice that this is the same thing that you used previously as source control. Masks work both ways. And finally, you need a person who's infected. And we're not worried about the asymptomatic transient infections, which don't cause onward spread along COVID, and which are more likely, dramatically more likely to occur if somebody's vaccinated. The vaccines work. They provide long-term protection against infection in severe cases and short-term protection against cases occurring. Prior infections inferior, and it comes with various risks, which is why it should not be encouraged. The first speaker will be Julia Ralfman on how important masks are and why kids can wear masks. These
It
are
doesn't seem like I
units.
can share my screen. I was trying to share. Do I have permission to share?
Sure, you can show.
Let's see.
You just have to press the button to the right of the microphone.
Yeah, that's what I did. The share button is, oh, there we go. I worked it up. Thank you. Okay, so I'm sharing my whole screen here. Hi, everyone. I'm Julia Ralfman. I'm an assistant professor at the Boston University School of Public Health, and I run the COVID-19 U.S. State Policy Database. So we've been tracking the dates that states changed their COVID prevention policies and policies to address economic precarity since the start of the pandemic. And we were actually mostly focused on researching policies to address economic precarity until the mask policy guidance change in May. And we were concerned by that and started to do a lot of work to try to communicate about preventing COVID-19 infections in that context. So that's the perspective I bring to this talk. So the summary of my talk today is that vaccines and masks are our most effective tools for reducing COVID cases and deaths. Mask policies help us take coordinated action to reduce the chance and amount of COVID in the air, something no individual can do on their own. And data-driven mask policies support people in wearing masks together when and where it is most important, for Delta or for new variants. So why do we need masks when we have vaccines? Vaccines remain 90% effective for reducing hospitalizations and deaths, and vaccines reduce cases, but not as well as they do for prior variants. But most importantly, 42% of Americans are not vaccinated. We also need further data on long COVID and severity of repeat infections, even for people who are vaccinated. There are also large disparities in who is vaccinated that reflect that there are structural drivers of vaccination access and information. So people in low-income households have been less likely to be vaccinated throughout the pandemic. These data are from September. Masks reduce COVID in the air and COVID that's inhaled. And in a lab test with dummies, exposure to infectious aerosols decreased by about 95% when both people were wearing tightly fitted masks. The logic of mask policies is straightforward. The idea is that we want the person with COVID and the people around them to be wearing masks. If just the people around them are wearing masks, then there's more likely to be COVID in the air. But if everybody, including the person who has COVID, is wearing a mask, then there's less likely to be shared air, less likely that the people who don't have COVID inhale COVID. The same is true in schools. In high transmission settings where there's no mask policy, but some students may choose to wear masks, there's likely to be a lot of COVID in the air because in a classroom with 30 students, there may be 1 or 2 students who have COVID and they may be breathing into this shared air. In that context, it's hard even for the student who's wearing a mask to entirely prevent exposure to COVID. When all students wear masks, that it reduces the amount of COVID that's breathed into the shared air and the chance that any COVID that is in the air is inhaled by students. So even imperfect mask wearing can help reduce COVID in the air and reduce the chances that students inhale it. We have strong evidence that state mask policies are associated with reductions in COVID case growth. These are 2 different studies that compare case growth over time prior to states passing mask policies and then after states passed mask policies compared to over time in comparison states. And both studies find that there's about a 2 percentage point decline each day in COVID case growth by the end of the study period. There's also expert consensus that masks work. This survey was conducted immediately prior to the CDC's change in mask policy guidance, and more than 95% of epidemiologists reported that they thought people should wear masks for at least 6 months longer, and this was before the Delta variant came. Speaking about misinformation, we did see that the opinion pieces in major newspapers really reflected people even less than in the necessarily 5%, people who thought we should consider taking off masks imminently once vaccines were available. When the CDC changed their mask guidance in May, we saw a steep decline in mask wearing. We also tracked state policies, so we followed states as they eliminated their mask policies, and that's what really drove this decline. In 2020, 43 states had mask policies. Several of them had dropped their mask policies prior to the May decision, but with the May decision, any remaining states except for Hawaii dropped their mask policies in the summer of 2021. And it was hard to bring mask policies back. Only 7 states and the District of Columbia have had mask policies during the Delta surge. This is from data from September of 2021, and we first noticed the beginning of the increase in child hospitalizations in July, mid-July of 2021, and we started to communicate a lot about what we saw as a very concerning rise in child hospitalizations and hospitalizations of young people, many of parent age, knowing that already we had lost too many parents to COVID. It happened within a matter of weeks that we went from record low hospitalizations in each of these young age groups to record high hospitalizations that far surpassed even the peaks from the prior winter. And while there was talk of decoupling, what we ended up seeing was that there were record high deaths ultimately for young people. So higher deaths during the Delta wave than at any prior point of the pandemic, including the surge last winter. At this point, there have been 145,000 deaths during the Delta wave. The deaths, of course, continue. The surges continue in several states, many of which do not have mask policies. And I'm concerned that they too will see record high death rates in young people. So as a way forward, we suggest data-driven mask policies that are a practical, rational, unified, politically feasible approach to addressing the COVID surges, managing the pandemic, and supporting the economy. Surges are bad for everyone. They're bad for labor supply. They're bad for businesses. They're bad for the leisure and hospitality sectors. And controlling the virus is good for our health, for our lives, for the economy. Nevada has a model policy that is very simple. It is accomplished in one paragraph. And it's this section 2 right here, and it just links the Nevada's policy to county level policies to the CDC transmission guidelines that suggest if there's moderate or low transmission in a county, they can turn off the mask policy. If there's substantial or high transmission in a county, then they turn on the mask policy. And low or moderate transmission must be maintained for 2 weeks before the mask policy turns off. I also want to highlight that that mask policies are not the same as stay-at-home orders or school closures. And in fact, I think of them as the opposite of stay-at-home orders or school closures, because they allow people to stay safely in school. They allow people to safely engage with the world and go to businesses. And they can actually prevent worse harms like school closures. And of course, the high rates of illness and death that we've seen. So we hope these policies can be an option going forward, and look forward to the discussion today.
Thank you. We're next going to hear from, can you stop sharing your screen?
Yes, I will try.
We're next going to hear from Nicholas Smit on, we're going to hear from David Eldridge on the mode of transmission.
Theo, thank you for inviting me to say a little bit of something about my passion here in this pandemic. And I've been following Theo, going on almost the entire pandemic, and he's been so passionate about these mitigation factors, and it's just been fun to watch his passion. So I am going to try to share real quickly here. Where is it? No, window, where is my... There it is. How come it's not showing? Wait, window, there we go. Ah, got it. Okay, there we go. So from the beginning. Okay, so I can't see you now. All I can see is my presentation. So I don't. The title of this little spiel is anisotropy. That's how it's pronounced. This is a term that Don Milton used. Actually, he said anisotropic when he was talking about influenza and saying that the route of infection matters, as we see down here. And we know that influenza is airborne based on all these studies that Don Milton and his team have done and so many others. And so we suspect that maybe there's some overlap in the same type of transmission mode. And let me just point out this one little video. If I get nothing else to you today, it's this one presentation that he did September 20th, 2020, or actually it's the 22nd of September. And here is a tiny URL to this presentation. And so you can take a screenshot of it or jot it down. And so I'm just going to play a little blip here if I can, if this is going to work. Tell me if you don't see it or hear it. So I'm going to go to 1400 or 14, and about right there. So Theo, can you hear it?
No.
You can't. Okay. What about now? Can you see it? Am I not sharing it?
You'll just have to change which screen you're showing.
Okay, thank you. Let me see if I can get there real quick. Okay. Click on share. Again. So if I do this and go to here.
And just start the video. Is that muted?
You're not hearing it? It's not working?
No.
Oh, bummer. Okay. Well, can you see the screen?
We can see it.
Yeah, you can. Okay. So basically what he's saying here is he's saying that influenza has been studied extensively for the past 40 years. And they did some trials where they inoculated people with the influenza virus with aerosol. And they became highly infectious. The transmission was really high. And they got full-blown influenza-like illness, fever, and the whole works. And then on the flip side of that, they took another set of people and inoculated them through the nasal pharyngeal area. And they didn't produce, the symptoms were just so mild. And in order to get a full-blown influenza-like symptom,
maybe doses of waves. They are about.
They had to go like 80,000 to 180,000, tissue culture, infectious dose, 50% to get anything to happen. But even still, they couldn't transmit. And so at the end of this slide right here, Dr. Milton says, the route of infection matters, that it's anisotropic. And so we suspect that maybe we're seeing something very similar with SARS. And then if we go to 2400, let's see if we can there. This was a randomized controlled transmission study that he and Kathy Noakes
what you have done is incredible.
and Jonathan Van Tam was the lead PI. Don Milton was a co-PI.
If you have any question, you can just ask me
And-
directly. Welcome.
I hear somebody else chatting. Am I?
Please continue.
Okay. So anyways, the bottom line is they basically reproduced what that earlier slide was. And they just published this past summer, actually the summer prior to this. And they could not get anybody to transmit the virus. They dosed people up with, just inoculated them quite heavily in the nasopharyngeal area. Some of them had some mild symptoms, but nobody was able to transmit the virus. And so, again, it just shows that the aerosol is so important for the transmission. So, okay, so let me get out of here and go back to where we were. Okay. So anyways, I'm just going to go ahead and end it right there. But anyways, like I said, I've been following Theo and everybody that's on this team COVID Airborne, and it's just been fascinating to be a part of this. And that's all I've got to say about it. Thank you.
Thank you. Now we'll go to Nicholas Smit on the importance of respiratory protection.
Perfect. Can you see that? Let's see. Can you guys see my my PowerPoint?
Yep.
Okay, perfect. So I just want to start off by saying I've been an advocate for better masks since the beginning of the pandemic, and actually worked with the Canadian and Ontario government to get elastomeric respirators recommended for healthcare workers. And the need for better masks is not something that's new. It's something that's been well known, and something the CDC actually did in previous pandemics, including SARS, was use a precautionary principle to warn healthcare workers not to use surgical masks unless it was a last resort, until scientists could actually prove there was no possibility of airborne transmission. So in Canada, the SARS pandemic created over 400 infections and 44 known deaths. This pandemic resulted in billions of dollars in lost GDP. And once the pandemic was over, the Sars Commission, led by Justice Archie Campbell and Mario Possemi, was created. This commission found the government had never used the recommendations learned from previous inquiries, so they kept
things. Can you go down on your slides?
Oh, sorry. Did it go to the wrong slide?
No, you have. Can you start moving your slides forward?
Oh, yeah, sorry. Like
Nicholas, I think the problem is that sometimes you cannot see when you got into presentation mode.
Mm-hmm.
I have the same problem. I cannot show in presentation mode. So just show...
Kind of like this? Does that work better?
Yes, now it works.
So I can't see what you guys are seeing, so I'm just
Yes.
fly blind a little bit. Perfect. Okay. So the most important lesson to come from the SARS Commission was to use the precautionary principle for future pandemics. This principle states that we must assume the virus is airborne until we can prove with certainty that there's no possibility of airborne transmission. This means using PPE, which protects against airborne transmission, such as N95s or higher. Additionally, healthcare should be warned to only use surgical masks if higher levels of PPE aren't available, since they have gaps that allow infectious particles to easily get through and infect them, the wearer, and those around them. So did Canada learn from SARS? No, we did not. In March 2020, Canada abandoned their plan to use a precautionary principle and still denies airborne transmission is happening. While American healthcare workers are banned from using surgical masks around COVID patients and forced to use N95s or higher, Canadian healthcare workers are prevented from using N95s or higher and told they only need surgical masks around COVID patients unless they're performing an Agmp. In May 2020,
what's an Agmp?
It's an aerosol generating medical procedure. So it's the procedures that are more likely to produce aerosols when, such as like cleaning, like dental cleaning, putting in a tube, different when you're working with the mouth or sneezing, different aerosols could be coming out of the patient. So it could be very dangerous for the workers around the patient. So that's when they're going to be using the N95s. That's the only time the government says that there's airborne transmission is during these aerosol medical procedures. So in May 2020, the Ontario and Canadian government recommended elastomeric respirators as N95 alternatives. Elastomeric respirators are reusable respirators which typically last years and use N95, N99, N100, or P100 filters. They are available from dozens of manufacturers, and the CDC has recommended healthcare workers use them for SARS, H1N1, as well as COVID. And the CDC also use them to protect the most at-risk healthcare workers in their infectious disease hospitals, such as the Texas Center for Infectious Diseases since 1996. Since the recommendations to use elastomeric respirators are never mentioned by politicians or journalists, healthcare workers are often actively prevented from using them, since hospitals don't know they are safe. Due to lack of awareness, high-risk workplaces that would greatly benefit using them, such as food plants, warehouses, schools, restaurants, correctional facilities, and stores, don't even know there are options that they could use to prevent all their workplace transmission, or the majority of workplace transmission. Provinces like Ontario bought over 100,000 elastomeric respirators, but since they refused to tell journalists, they were able to quietly lock them up without any public pressure to use them. Healthcare workers are often told when they ask for elastomeric respirators that surgical masks are good enough and that higher levels of protection from elastomeric respirators just aren't needed for COVID, since it would be overkill to use them. The government has turned down countless offers for NIOSH and Health Canada approved N95s and elastomeric respirators since last year, while telling healthcare workers to keep reusing their N95s for weeks at a time due to a non-existent PPE shortage. Canada refuses to explain that N95s and elastomeric respirators provide better protection than surgical masks and continues to say N95s aren't needed for protection from droplet transmission. Despite the government admitting cloth and surgical masks don't offer the wearer protection from infection and only reduce their chances of spreading it to others, which is called source control, they still won't recommend N95s or better for the public, which can actually prevent transmission in both directions. The lack of airborne recommendations has enabled employers to punish employees such as teachers for using N95s or higher levels of respirators. And federal agencies were told not to put their studies showing airborne transmission online and to make it extremely difficult for anyone who does know about those studies from getting a copy from the government. Some politicians, like Liberal MP Ryan Turnbull, spent months trying to convince his leader Justin Trudeau to publicly pressure the provinces to use their stockpiles of elastomeric respirators. And he also asked ministers of health to warn Canadians about the importance of elastomeric respirators and needing airborne PPE, since they have well known for a long time that droplet protections have not worked and have failed to stop the spread. Since the federal election was only months away, the government refused to follow those recommendations, and Ryan has stopped fighting for transparency. So what have we learned as a result of Canada ignoring science in past lessons? Well, because we have not used proper masking, Canada has over 1.7 million documented cases of COVID, over 28,800 deaths, and using a conservative figure of 10% of cases becoming long COVID, at least 170,000 Canadians now have to learn to live with new disabilities. Our supply chain is also in turmoil, and COVID has caused significantly more economic damage to our country than SARS and H1 combined. Since the government refused to inspect nursing homes during the pandemic, a lot of residents died not just from COVID, but also from neglect due to dehydration and malnutrition. And domestic PPE manufacturers have significantly slowed down production, with some closing down altogether. Manufacturers are still banned from advertising they have N95s or elastomeric respirators available, and the government still won't recommend domestic PPE and says N95 should only be used by healthcare workers. So if this continues much longer, Canada might not be able to rely on domestic manufacturers of airborne PPE in future pandemics. Some provinces without room in their ICUs have to airlift patients every day, thousands of kilometers or miles away to other provinces. And a lot of experts are afraid to speak out now about airborne transmission and the need for airborne PPE due to the pressure and facing punishment from their employer or the government, so this will only continue to get worse. Thank you for your time today. On the right is a mask classification table I created to help people easily understand the type of protections they get from each type of mask, as well as if it is from droplet or airborne transmission, the type of protection they get, and if it protects them as well as those around them. So it makes it easier to understand. And when people go to places like hospitals, they're often told to take off their N95s because hospitals only recommend surgical masks. So this will also help prevent having to downgrade protections just because it's not, the higher levels aren't recommended. So thank you for your time. And if you have any further questions after this presentation or need additional resources, I also put my contact information on the left. So thank you, everyone. Cheers.
Thank you. Because it appears that our speaker on task is not present, I'm going to turn to Gosia to discuss the vaccines and why they are not enough.
Good afternoon or good evening, everybody. I'm Gosia Gasperowicz. I'm developmental biologist from Calgary, Alberta, Canada, and I'm member of Zero COVID Canada and also of Protect Our Province, Alberta. So both are grassroots organizations. I would like to talk about, so I observed the pandemic dynamics and how COVID spreads and how it all goes since 1.5 years. And now I would like to talk about vaccines and what they can do and what they cannot, but especially about the spread, how they influence the spread. So I'm not talking about how they protect us from severe outcomes or deaths, but how they influence the spread. So first of all, I would like to tell about R value. And I'm sorry, I have to fix something here. Can you see the whole slide I'm sharing or just a part of it?
We can see the slide, but if you went into slideshow mode, it would appear larger.
I can. Then it won't. It's the same for what was for Nicholas, that it
then
won't
you can
flip
just
the
continue.
slide. Is it better now? Like, I try to make it as big as possible.
You can start.
Okay, so R0 tells us how many people on average one infected person would infect if there would be no vaccinations and no public health measures. So R0 of original variant that caused Europe's first wave was around 3. So one infected person would infect 3 people without public health measures and change in behavior. But since then, virus evolved and became more transmissible. So now Delta variant R value R0 is between 5 and 8. So I assume it's around 6. And then another number, RT, tells us how many people one person would infect if under current situation, so under vaccination and public health measures. And this, if R value is below 1, it's good because cases go down. If it's above 1, it's bad because pandemic continues or epidemic continues. So on this graph, I show theoretically if could we get R value below 1 with vaccines only. So probably with R0, with original strain of R0 that was 3, if we would have 93% efficient vaccines against overall transmission, and if we would vaccinate 75% of total population, then we could bring this R value down to 0.9. And starting from 100 cases, it would take many months to get to 0, but the number of cases would decline. What we observed 1.5 years ago, or something like that, we could, with just bundle of public health measures in many jurisdictions, we drove down R value from R0 of the original variant to 0.5, 0.6, 0.7. So basically, these are observable data from many jurisdictions. R of 0.6 was observable in Melbourne, lower R was in New Zealand and in Austria. So, and jurisdictions that kept the public health measure bundle for long enough time, they were able to stop the transmission. If a year ago we would have vaccines on top of public health measures and combine them, we could get this green line and really stop the spread in 2-3 weeks. But what happened since then? Since then, we let the virus spread, and now we have Delta that is twice more transmissible. So what worked for original variant, bundle of public health measures, now with twice more transmissible variant, it would result in R 1.2 and would be not enough to bend the curve. Vaccines alone, if they are only, for example, we don't know how efficient they are against overall transmission. 80% is in the estimate range. So if it will be 80% efficient against overall transmission, and if we have 65% total population vaccinated, still we could get down R from 6 to just 2.9. So still we would have the spread. If we would vaccinate more people, so not 65% by 85%, we would bring R down to 1.9. And so this is situation if we would use vaccines only. So we would do no public health measures, no changes in our behavior, and we would behave like it's 2018. But it's not like, still we can beat Delta if we have vaccines and public health measures. If we combine those two, we can get the green line, which gives us R of 0.58, which is quick. So from 100 cases, we can get in 35 days to 0. So this is theoretical, right? Like the kind of basic vaccine math. But what happens? Okay, so first I show another way of showing the same concept. So on this line we have R values, R0, 2, 4, 6 to 8. So original variant, alpha variant, and delta variant. Here, how many people in the population need to be vaccinated to get to herd immunity, so to stop the transmission just by vaccination. So if the vaccine would be 95% efficient, then for Delta we would need like almost 100% people vaccinated to stop the transmission. For if it would be 60% efficient only, then for Delta variant, we would need to vaccinate 140% population to just stop the transmission, slow down transmission, just like to bend the curve just by vaccination and not doing anything else. So with low efficient vaccine, it's really not possible. Okay, so what is happening in reality? Those are daily new confirmed COVID-19 cases per million people in Denmark. That was mostly Delta variant here. And we can see that with public health measures and vaccines, Denmark was able to bend the curve of Delta. So they had decline in cases. But what they did, so it's possible to control Delta with the combination of public health measures and vaccines. At this time, they had 70% of total population fully vaccinated. But what they did later, they lifted almost all internal restrictions, except of some travel control. And 12 days later, cases started to go up. Now they have 76% total population fully vaccinated, but it's not enough. Cases are doubling every 9 days. So that shows that we definitely need both public health measures and vaccines to control Delta. This graph shows daily new cases in Alberta, the black dots. We also managed to, so that was basically mostly Delta variant here. And in Alberta, in Canada, we managed to bend the curve with public health measures and vaccination, we have 68% people fully vaccinated, and very, very mild public health measures. If one would just elongate this, so keep this R value of 0.84, it would take more than 140 days to get to zero. So it's very, very long time. And then usually politicians are not patient enough and they would drop mask mandates and something, and then cases would start going up again. But if we could put more public health measures and push R value to 0.5 or 0.6, then in 5 to 8 weeks, we could stop all the community transmission. And the measures that we can use to do that. So first of all, the classical thing in green zone strategy is protecting the area from importation of new cases from outside. So quarantine, tests, and vaccine passports. Then stopping community transmission. It can be by shutdown. So strongly financially supported shutting of non-essential businesses and in-person schools for several weeks until the community spread is stopped. But many governments won't do that. So limits on gatherings, vaccine passports also belong to this group. And then there are some sort of easy and light touch, low-hanging fruit measures that so there are good tools for both stopping community spread and for preventing reintroduction. Because if you use vaccination, even if something leaks from quarantine, then the population is more resistant. So then this small epidemic that starts from this case is much slower and easier to catch. So basically, vaccinations, we can still, at least in country like Canada, where we have a lot of vaccines, we can much more actively vaccinate people and especially give people the third shots. Airborne precautions, so people already talked about it. It's such an unused tool. Like we really could protect people much more with using airborne precautions, and they could, like, using masks, using air filtration and ventilation could really reduce our value very easily, because we don't do that. So if we do much more there, then we could reduce the spread, and using rapid tests in a smart way. So using it when cases are low for preventing the spread. So testing. So all these tools can be used in different way, and the framework is really important. If we want COVID to spread and live with COVID, then nobody would use it because we are living with COVID. So why to bother when we don't have super high wave yet? But if we aim for elimination, we look at the tools totally different. We use all of them to stop the spread as fast as possible, and we are becoming much more effective. So, for example, we use them proactively instead of just reactively, and use them in parallel instead of in sequencing in sequence. So thank you very much.
Thank you. Because we did not have a speaker on the rapid testing, I'm going to start there. We know that early on in the pandemic in the United States, they had difficulties getting tests out. The CDC in Atlanta took all the tests, and it was really slow. It took weeks to get test results back later on, and they did not change from a PCR type system to an antigen testing system. So my first question is, what are the consequences of people not being able to get tests rapidly, similar to how they do it in the UK, where they give tests twice a week, or in France. No, sorry, Germany, where tests are like $1, and they really want people to take these rapid tests.
I can maybe answer that if so the reason why it's important to make sure you're testing everyone is so we can stop the community transmission, because with Delta it actually takes less time to infect others. With the old strains, it used to take about 6 days between the time you get infected and the time you infect others, but with Delta it's down to about 4 days, and there's even documented cases in the UK where somebody got infected at a soccer game and 30 hours later infected somebody else. So if we don't test, we'll miss a lot of cases. And since people are vaccinated, they are going to be less likely to go to the hospital, just more likely to have mild flu-like symptoms or cold-like symptoms. So they might not even realize they have COVID, and they might continue to go to work. They might send their children to schools, and then it'll continue a cycle of transmission.
And we know that public health officials have been begging for people to get tested. Yeah, we hear governors having said, and the CDC even saying, if you're sick or if you've recovered recently or if you're vaccinated, don't get tested. We also know that essential workers often don't have access to tests because their employers don't provide it. So what are the consequences to public health when you can't test quickly because you don't have the access? I would like to say we don't have to ask this question, but sadly, we do have to ask why essential workers can't get the test and the time off if they're positive or close to somebody.
I'm really glad you're asking about essential workers, and I think equity is a major issue here as well, because essential workers are most likely to be exposed, actually continue to be less likely to be vaccinated, and to be in workplaces where their transmission may happen to colleagues. So I think access to rapid testing is especially important in essential workplaces. I'm also really worried because we see that repeated infections are possible, that immunity from prior infection wanes, as well as immunity from the vaccines. And I think we haven't done much to communicate that essential workers are eligible for boosters or encourage them to get boosted, even though they could help reduce onward transmission and reduce severe outcomes. So yeah, I think that rapid tests are key to preventing transmission in workplaces, and essential workers should be prioritized for all interventions. Mask policies that protect essential workers who work in congregate settings, vaccine delivery to essential workplaces where many people remain unvaccinated, and rapid testing and ventilation.
So we got a question in the chat, which I was going to address that, so I'll do it now. The CDC on May 13th issued guidance which said that if you're vaccinated, you don't actually need to wear a mask. They did this, and they should have been fully aware that people based on behavioral health who are unvaccinated and are anti-vaxxers are likely to unmask because, of course, there are also anti-maskers. why did they think that the vaccine incentives would work when studies have shown that these sort of vaccine incentives have actually not caused people to choose to get vaccinated?
I think that decision was a historic policy error that will likely have ramifications, potentially for decades. I think it was based on considering public health from an individual perspective rather than a population perspective. And thinking about individual level interventions like vaccination that is delivered to individuals rather than policies that control COVID in the air for the whole population. I also think at the time less than half the population was vaccinated, and so that was a major concern for equity. And put the population at risk. It might have also been overconfidence that trends would continue to go down. But I think it's important to understand what happened then. Obviously, the deputy director stepped down when that decision was issued. And I think understanding that will be important for moving forward.
And that decision also came 6 days after the CDC finally admitted airborne transmission was happening. And at the time, journalists were also wondering, now that CDC admitted airborne transmission was happening, will they finally implement N95s or better for workers and not just healthcare workers? Because that's what was supposed to be coming in the emergency temporary standard. And in the original draft, all the workplaces were supposed to have proper PPE, and that got removed once the government started saying vaccines alone were able to stop enough of the transmission. And despite the CDC director in early August admitting that it no longer did a good job preventing transmission, those protections actually never came back into the emergency temporary standard. So people like Theo are constantly fighting to try and get the protections workers were promised over a year ago.
So I'm going to step in and say what I saw in the emergency temporary standard was, which they did previously, was that it included various levels of protection for virtually all workers. It did not say that everybody needs an N95, but they took at one of the grave errors that they made was they said, if you're vaccinated, you're no longer at grave risk. So, and if the vaccines are available to everyone, so outside of healthcare, the risk is very low, so it doesn't even qualify. Then they sent a letter saying that even in healthcare settings, that people are actually exposed to the virus. The only thing that was seen was the only case actually where healthcare workers are at greater risk is in places like Canada, where studies show disproportionate burden on healthcare workers compared to even essential workers when they're seeing COVID patients without respiratory protection. I can't understand why they made that decision that healthcare workplaces are somehow different and transmissions different in healthcare workplaces compared to everyone else, especially because those aerosol generating procedures that you're discussing are a myth. Studies show repeatedly that talking's much more dangerous. So I'm going to go into a vaccine question. Given that what Ontario's saying, which is we'll wait months before we can let kids get vaccinated, and what the UK Joint Committee on Immunizations and Vaccination says on chickenpox, which is people would no longer catch chickenpox. That means unvaccinated kids are most susceptible, that it can reactivate, and that vaccinated people means you don't get natural immunity. Despite even Tao Healy 2019 publishing in Scientific America, that means fewer kids get shingles. Why do you think these policies on delaying vaccinating kids which are of course Great Barrington policies, are continuing to spread?
Well, I think any mitigation measures for a lot of companies can cost them a lot of money and can cause business disruptions. So the corporations are the people that have the money and the lobbyists to work with politicians from both sides. So the vaccine and even masks became a very politicized issue. So it takes a lot longer to implement the proper measures because there's a lot of people fighting and they don't want to use the measures that are effective because it could be a political problem for them. So we know that it is safe. We've seen in the US, they just approved it. So Canada, by delaying that vaccine, it's going to mean children are going to be more likely to be hospitalized and die if they do get the Delta or the Delta Plus. But it also means that they're going to be more likely to spread it to their parents as well, because it does reduce slightly transmission, but it doesn't do it well enough so that in their households, they could still transmit to their parents who are fully vaccinated. And then those breakthrough infections can continue from their parents to their workplace and continue a cycle of workplace transmission in that community.
Yeah, and also there's a very dangerous idea, and it seems that some public health people believe in it, that children are not at great risk from COVID. So we can infect them and it gives them immunity and everything is great after that. So, and I read such statements. So it's it might be just this sort of underlying plan to get them infected with natural pathogen.
It's tough because in Puerto Rico, they've announced today that they're actually going to be mandating the vaccines for children. Yet, what we're seeing is people claim religious exemptions from the vaccine. The vaccine with Canada delaying in months. The Air Force granted over 1,800 medical exemptions from the vaccines. And public health has just said that we really need people to get vaccinated. It's not going to really work. So I'm wondering, with 99.5% effectiveness in vaccine mandates, why are states in the US being blocked from doing this policy that's known to save lives?
I think if one state does a great job and introduces airborne recommendations and they stop the spread, then the other states would then have to take notice and make those difference. And there's no really incentive for changes to be made. The government has admitted a long time ago in the CDC that there was airborne transmission. They admitted that vaccines need additional layers of protection in order to be effective. So by allowing the virus to spread, they're actually going to make the vaccines less effective in the long run. So it's not necessarily a good thing to prevent these states, but it's going to make it harder. It's going to make it harder for all the other states to then get better protections for workers and for children to get the vaccines as well.
Because where it gets tough is the vaccines are one place, but if you look at mass and on this, first of all, the CDC infection control people, which is Project First Line, are saying that it spreads through respiratory droplets. And I saw that it's a highly charged political system in the US. I agree, but why is it taking such a difficult time with even the CDC's infection control for healthcare admitting that it's airborne, which they denied as recently as last month in a Project First Line presentation?
This is just a theory, but one of the theories why the government is so hesitant to make sure there's a more focus on airborne transmission and proper masking is currently the liability is on the worker. If it's just droplet and you get it from contact surfaces, then if the worker gets infected, it's on him or her. But if the employer then has to admit that there's airborne transmission and need higher levels of protection, and the employer gets infected, then it's on the employer that would be liable for that infection if it's in the air.
So why can't you say that we know that it's airborne, which means we know how to stop it? We know that it's going to use Cozy Rosenthal boxes, which is do-it-yourself HEPA filters, not these ionizers that the American Chemistry Society and these other things that the American Chemistry Society says. Foggers that the CDC in 2003, 2008 said not to use for patient care. Toxic things that harm the respiratory and reproductive tracts. Using disinfectants when it's not going to stop anything, or even saying hand hygiene, although they should be encouraging hand hygiene for a variety of other diseases, not COVID. So I'm completely pro hand hygiene, but why can't they say that even PPE, you can use a gown and gloves, but that's wasteful environmentally. It should only be used for one patient as a contact precaution. Why do you think they can't say that it's airborne means we know what needs to be done, we know what we don't have to do, which will save employers money?
Well, if they say it's airborne, they can't use surgical masks because the CDC has long admitted surgical masks don't offer airborne protection. So it would then be N95s at a minimum. And even if they say it's droplet, N95s do a much better job of protecting from droplet transmission than surgical masks. So the argument that we can't use better PPE simply because it's droplet protection is one I don't understand why more people don't fight back and say, well, if it is droplet protection, why don't we use the best masks for droplet protections, which are N95s, N99s, N100s, and elastomeric respirators.
Oh, how about, have you seen the studies on continuously wearing an N95 actually being safer in a hospital compared to both single-use N95s, which the CDC says is conventional, or these surgical masks? Because there's been multiple on that. Pre-pandemic saying it's been safer.
So I think pre-pandemic was also because the virus transmission in hospitals wasn't as big as it was. It didn't have a big impact as it does on COVID, where it's throughout the entire hospital. It might be one patient or two patients. So then the virus is localized to that area. But now that it's throughout the entire hospital, no matter where you are in the hospital, it could pose a great danger to you, and it could linger in the air. So if you're going down a hall, even if nobody's in that hall, you can still get infected from somebody who walked by there 10 minutes before.
Yes, and that's actually been seen, but with the need to protect healthcare workers, we're seeing that you need, in North Dakota, here's how crazy it is. North Dakota, a person came out and said that OSHA requires a medical evaluation before you're fit enough to wear a mask, and that's how they ban mask mandates.
So even if you don't get fit tested, the N95 and especially elastomeric respirators will still provide a much better fit than the surgical masks, and it would still give you great protection. There's some great studies that came out at the end of September led by CDC scientists that show surgical masks on their own, they only prevent about 55% of virus particles from being breathed in, and they only prevent 45% of virus particles from being exhaled to the outside environment due to their gaps. But such a simple solution as adding a brace to the surgical mask, which people can make themselves or buy one, will actually provide it protection similar to an N95, since all the air would then go through the filter material of the surgical mask instead of through the sides and sometimes through the mask.
But what I was trying to discuss is the harms that you're saying people can be caused by wearing a mask, and it's fictitious. Things like masks can cause eczema, conjunctivitis, higher CO2, low oxygen levels.
I don't know if you can give me a moment. This session, I don't know when you started, but it's supposed to be completing, and there's a new session in SA which has Raina McIntyre and three people. Sunil Raina as the last person, and also Shuti Chow. So the three of them are supposed to talk during this hour. So if people want to join, they can join for that session as well.
Thank you for that announcement.
Sorry to interrupt your presentation.
No, what I was about to discuss was that when we get to children and wearing masks, it's even tougher because the WHO says kids under 6 shouldn't wear masks, and kids 6 through 11 should only wear it under certain circumstances. The European CDC says kids under 12 should not wear masks in school. What has been the harm to those policies which disagree from the CDC and the American Academy of Pediatrics?
Well, I think there's quite a bit of harm because masks are not only used for COVID, and respirators like N95s, they're actually commonly used in construction, mining, agricultural, pharmaceutical. People wear them all day long. This is not a concern that has been brought up when the people use it all the time. It's people that often are anti-mask that use them. And then you also have to think, it's not just the virus that will harm people, but people are getting a lot of anxiety from going to work, from going to the store, because they're afraid of that infection. And the people that so they stay home, and then they have all kinds of other side effects like depression. So simply not using a mask because it has the potential for 1 in 1,000 people getting you acne, it's just the same as bad as the vaccine saying don't take the vaccine because it has 1 in a million chance of giving you myocarditis,
which is actually less dangerous than and less likely than if you got infected with COVID.
Mm-hmm. And even birth control is more likely to cause blood clots than the vaccines, but we don't ban birth controls and we don't prevent people from taking birth control. So it's more of something to scare people away from taking the right protections. Because if more people are taking masks, then more employers are going to have to provide masks to all their workers. They're going to make sure their customers are wearing masks and that they're also being worn properly. When now people are often allowed to get away with it while wearing it under their nose, on their chin. And it's people are now saying masks don't even work at all. So it's more to get people against masks without actually providing accurate science to the people.
And Dr. Ralfman, my question is going to be, they even claim that it harms childhood development when that's the European Centers for Disease Control for kids under 9, when studies show that for most kids, yes, there are going to be exceptions, that it's actually really safe for kids to wear masks and doesn't cause developments. Why are these childism policies occurring, and how is it actually harming kids?
I think it's that the debate has been focused on masking kids instead of the bigger picture of reducing transmission in the whole population. Certain schools are a crowded indoor setting where the virus spreads efficiently, and it is important to have mask policies there. But really, adults should be masking too to reduce transmission in similarly crowded indoor settings. And so, I think that partly we have ended up focusing the debate on child masking because people who are anti-mask have focused it there. I think that we can acknowledge that we all prefer not to wear masks, and that it might be more pleasant to engage with each other, and could conceivably affect child development, though we don't have much data on it, but that the harms of COVID far outweigh the risks to children, especially because they have opportunities to interact with people not in masks outside of school, and if they're not required to wear them outside. So I think that the harms of COVID for children should absolutely include the risk of orphanhood, because that has happened to a lot of children, that they may acquire COVID in schools in crowded indoor settings and then bring it home, and there's a very high secondary attack rate in households. So those harms are of course much worse. Losing a parent or caregiver is far worse than any temporary effects to child development of wearing a mask.
And what I was going to say is, we have actually seen that 2 states actually require them outdoors even though there may be some evidence of spread, it's very minimal. Yeah, we don't, and of course kids are very good at wearing masks. Yet, when studies show that mask mandates actually drive people to wear masks, which cuts transmission down, we're hearing Florida's Surgeon General say, despite a CDC study in the fall of 2020 in Florida saying mask mandates work at reducing the spread, and I believe it's under 0.01 p-value, like a third lower, that masks don't work. How do we combat this disinformation?
Well, you could point to countries that did a great job with masks. It's not with children, but for example, China, they provided better masks to healthcare workers as of January 2020. So healthcare workers make up a very, very minute fraction or percentage of transmission in China. While in Canada, at one point, it was 1 in 5 cases was a healthcare worker because they didn't have the right mask. So it shows how easily masks can prevent transmission, even among the highest risk workplace settings, such as hospitals.
Because my question is, with mask mandates being very effective and vaccine mandates working, why do you think we're hearing Michigan that they are trying to strip powers? States have already stripped powers. In Texas and Florida, they may not actually notify a child of a close contact, which they'll say is 6 feet, 15 minutes instead of the whole room. And even if they notify the close contact, they still have to let the child come to school unmasked. The teacher doesn't have to wear a mask. Nobody has to wear a mask. And they can expose people, no remote learning, and just infecting people. How is that not traumatizing to kids to know that they're being exposed to an infectious disease as dangerous as COVID and adults are refusing to protect them?
I think it could be very difficult for children, and for children, they also live in households where the parents might be anti-maskers themselves or anti-vaxxers. So that information could get to the children and it's telephone tag, and then the children talk to their friends about it as well. So some children might not be afraid of the virus at all and might think masks are actually scary because that's what they're being told by their parents. So I think making sure we let children know that there is no dangers to mask use, there's no real dangers to vaccines, and they actually prevent all the scary things that they might experience from happening. And we could also make things like masks cool. So we could put maybe figure out a way to put designs on masks and things like that. So it's not something scary looking either for them. I think that can make a big difference for the children.
Well, kids actually know how dangerous COVID is. And what makes it worse is that in these states, not only don't you have contact tracing in schools or masks, vaccine mandates are banned in both Texas and Florida for both teachers and students. So I'm wondering, what are the consequences of just continuing to undermine public health as if they were having to deal with public health attacks and not able to do their jobs because people are just attacking what's right?
I think children are going to end up learning, especially in states like Florida and Texas, that some people's lives are less important than others, and that people should take risks even though there's no need to take a risk at all. I know in Canada, one of the reasons why we're telling teachers not to wear better masks, for example, is that they're at low risk. While right now, about a week ago, the Globe and Mail in Canada announced that in Ontario, 46% of all transmission is in schools or education centers. So the schools are where the majority of the transmission is happening. So it's not a low risk, and we can actually eliminate the risk. So there's no need to take a risk at all. It's like playing Russian roulette when you don't have to with a deadly virus. We can eliminate the risk so that it's a safe work environment, safe learning environment. And that way we can actually get rid of the transmission. And this will actually help vaccines become more effective so that there'll be less variants that can evade them in the future.
Thank you for that. One other thing I wanted to discuss is we see all the concerns about kids, but we don't discuss even pregnant women. In Alberta, they have said that if you're a caretaker, a support person who's COVID positive, they'll let you go into a hospital room with a patient somebody who's giving birth to a child. All they'll do is require contact precaution and droplet precautions. And of course, wear a mask, which is a surgical mask, because they don't recognize COVID's airborne outside of these procedures that are fictitiously producing aerosols. Yet pregnant women were found in the UK to actually be 20% of people in the ICU. With that disinformation, why are they endangering vulnerable people with COVID when they should be giving birth to a child in safety.
Alberta's kind of the Florida of Canada, unfortunately. So they often ignore science, and even after the mother has given birth, I've heard that in Alberta sometimes there could be 4 patients in a room, and they just split the room up with curtains. So it's not even mass sometimes that the other people have it. It's just a curtain dividing the a small room when somebody could be infectious. So then the entire room, then all the other mothers that are in there can be infected. They infect their partners, and then their newborns can get infected as well, because the newborns won't be vaccinated, so they won't have really any protection at all. And if their mother is sick, then they might not be able to get the proper development from the first few months as well. If the mother's in ICU and she's not breastfeeding the children and getting that development in the bond, it could really affect the children as well.
And of course, children can't wear a mask because those SIDS and all these other harms that young children can face of suffocation. But I think that it's scary that we're seeing all these policies because people can't even, or public health officials can't respect the science. And politicians don't want to take these reasonable steps to protect people. Instead of trying to do lockdowns, which, while they work, they require broad support plus these tools to actually eliminate COVID, which in most places, especially in the United States, is simply not feasible. And does anyone have any final thoughts on this?
Actually, like the lockdowns, they can be prevented altogether with vaccination, social distancing, proper masking, and things like the Corsi Rosenthal boxes in workplaces and schools. We can actually get rid of all transmission, and it could be economically better too, because if you think just of the stimulus checks the U.S. government sent out, that's trillions of dollars in taxpayer money. And if you look at providing every single American with their own supply of N95s or elastomeric respirators, that's $10 billion or less. And that money would also go to domestic manufacturers, so it could get reinvested through tax purposes and income. So it wouldn't even be that much for the government, and would actually stop the supply chain issues that are causing them a lot of money. And just their GDP alone, the third quarter, they only made 2%, or they only went up in 2%. So that's about $300 to $500 billion in lost money just from the problem with the GDP. And then this Christmas is going to be even more concerning because there's even more supply chain issues, and people aren't going to get their Christmas orders in time. So people are asked to order their Christmas products on time. So it's going to continue causing large economic consequences, not just the lockdown, but continuing to let the virus spread. We're going to end up slowly causing businesses to go under one by one. It's like death by 1,000 cuts. It's all the previous lockdowns. They can't now provide the products to their customers, and then their customers also have less money to buy their products because the price of everything has gone up, if you can even find what you need. And that's if you're lucky to still have a job. A lot of people are out of jobs as well. So it's going to have all kinds of snowball effects if we don't actually take the right precautions and make sure that more people get vaccinated, more people get the right protections, and more people know how to stop COVID and stop the misinformation from spreading faster than the virus itself.
David?
Yeah. Been enjoying the discussion here. This is great. So I question, when is this battle going to end? Are we winning? Are we falling behind from? I had the greatest hopes in the world when Don Milton and Lindsay Marr were making all these statements. Yeah, people are going to get this in the next couple of weeks, and it's going to be over. But I don't even know today. Where are we? Are we getting further behind, or are we making progress and people actually catching on? I know all of my state medical doctors, all the ID docs, they're still oblivious, and it's just driving me crazy.
So I think we are making a lot of progress, but it's not going to be from government. It's going to be from grassroots movements and things like this summit where people can learn from a lot of experts from around the world. And slowly, the governments are going to have to admit that they made mistakes. So the biggest thing for politicians is not to admit you made a mistake, especially one that cost thousands or hundreds of thousands of lives and cost billions of dollars in economic damage. So they're going to try and kick the can down the road, and grassroots movements and things like this is going to make it impossible to keep kicking that can, and they're going to have to make changes. So now they're realizing vaccines are great, but they're not as good without additional levels of protection. So slowly those levels of protection are going to have to come around. And when countries like the UK, the US, or Canada make these changes, the other countries also notice. So we'll cause pressure on these other countries to then follow suit, because they won't want to be the last country to get rid of COVID.
Or you can see the consequences of endemic COVID. Julia, do you have any comments?
I just want to make one suggestion, is that, like, you guys are brilliant, but I think it would be great to embrace social media, because social media is where you can actually reach billions of people. And I think that's a good channel where you can actually start grassroots movement. We successfully actually reached quite a bit of people there. And if more of us, from this summit will engage people on social media, flooding it with like great information, we can actually make a difference. But it will require all of us to like actually do this together.
Yeah, it's like that's some great points, Julia. Like, it's not a one person, it's a global thing. And social media is definitely how we can get a lot done, because news organizations, they write what the government tells them often. So they don't often write what the experts are saying, because the experts are told by the government that they're wrong, that there's no need for this, there's no need for that. So it's a great point.
And I want to share one thing is I heard on Twitter, WHO actually had all these video and animation to show people that they're not supposed to use N95 and medical grade PPE, and they want people to stick with cloth mask, which make mask advocates and other public health advocates have a really difficult time, because we know the higher quality mask is more protective, but then at the same time we're dealing with WHO saying that cloth masks are recommended for common people in their life, social setting. So there's a lot of obstacles that we have to overcome.
Actually, the WHO, even in H1N1, it was the same thing. The reason why the WHO was often just recommending surgical masks or cloth masks was because that's what was available for developing nations. And a lot of nations had N95 shortages. So to simplify it, they ended up just recommending surgical masks, while the US recommended surgical masks as a last resort as well for H1N1, unless like you couldn't find an N95. And Canada was following the WHO and H1N1 as well, and they were refusing to use N95s, and they were giving everyone surgical masks as well.
So, Dr. Ralfman, do you have any comments that you'd like to say before we conclude this session?
No, thank you. It was a pleasure to learn from you and from the co-panelists, and I think putting out accurate information like this is exactly what we should be doing, and certainly agree it's important to do in every medium, on social media and reaching out to policymakers as well. So thank you for organizing us.
You're welcome.
Yeah, thanks, Theo. It was a great presentation.
Thank you for participating in this. And I would say hearing the explanations is very important, because because I can say the facts, but you need to know why it's happening so you can actually stop it and protect those healthcare workers in Michigan and those public health workers in Michigan who are being threatened. So thank you for listening.
And something else we can do too is once the government is very slow to act. So once the news organizations, and it's common knowledge that airborne PPE does a great job at stopping the transmission, we can also turn to corporations to buy PPE for the third world, because if we continue to neglect other countries such in Africa, South America, and Asia, then this virus is not going to go away. They have a very low vaccination rate. They don't have hospitals that can keep up. So we're going to end up dealing with variants that are going to come from around the world, and then we're going to have to deal with economic consequences and having to support these countries because there's going to be so much economic damage from the virus that has gone ravaged their countries.
Yeah, if there's anything we can do together, just reach out, because we have a platform on social media. We are there to support everyone. We just have to keep spreading the word and educate the public, and also find opportunities that we can support and just end the pandemic.
Mm-hmm.
We can't live with this.
No, it's only going to get worse from here on in if we don't end up taking the measures we need now.
Yeah.
And what we learned today and next year is something we could use for tomorrow fighting climate change and other future emergencies.
Absolutely.
Because it's a global community. It's not one country or one person. It's 8 billion people working together.
Yes. And of course, the zoonotic diseases, they're actually occurring much more frequently now.
Mm-hmm.
Yeah, we better be more prepared for the next one.
Well, that's one of the good things with things like reusable respirators like Elastomerics, is since they can last years, some hospitals actually use them for H1N1 in 2009, stored them for 10 years and took them out for COVID. So if we give citizens and workers the widespread use of Elastomerics, anytime there's a future pandemic or virus that emerges anywhere in the world, we take them back out, and then it doesn't turn into a pandemic. It quickly, the transmission quickly stops in that localized area. So we never have to experience a pandemic again.
And, Texas Center for Infectious Diseases, they actually use one elastomeric for employees' entire career.
Oh, I didn't know that.
And they only change the filters annually with the fit test.
Yeah, they've had great success there. It's amazing more hospitals haven't tried to put them into widespread use, because after H1N1, the CDC plan for pandemics was to put elastomeric respirators into widespread use. And if you Google Lou Radonovich elastomeric respirator, you'll see the CDC presentations from 2017, 2019 that explain how surgical masks shouldn't be used because of the gaps that they were expecting N95 shortages. And one of the things that they were supposed to do during pandemics was NIOSH was supposed to quickly educate all the workers around elastomeric respirators. And that's something they just have not only did, they pretended like N95 reuse was the only option.
Even though that's safer than the surgical mask.
Mm-hmm.
I have to hop off, but it was such a pleasure to meet you all. Thank you for the session.
Thank you.
Thank you, Theo.
You're welcome.
Thanks, Theo.
Thank you, everybody. It was great.
It was a pleasure.
Thanks for your presentation.
Thanks.
Bye, everyone.
Bye-bye.
Bye.